Hey everybody, I'm Dr. Dan Thaluri. We just met in the clinic, and this is me recording basically our consultation for you so you can review it later. And I want to start by reintroducing myself. I go by Dr. D. I'm new to Beltline Bariatric Health, and it's been a pleasure to be here and start the journey with Beltline. And I look forward to going down this journey with you. Again, this is the post-consultation review seminar with me. I hope after today you're already feeling welcomed by our Beltline Health team, more confident, more educated, and more supported. But we did cover a lot today, and so I want to use the following slideshow to go ahead and review a couple of things. Why is it tough to lose weight? What are the surgeries and how do they work? And what happens next? So why can't most people lose weight by dieting and exercising? The main issue is something called metabolic adaptation. And as I described for you in the meeting today, the gut, your intestines, your stomach, your liver, etc., communicate with an area of the brain, specifically the hypothalamus, constantly. This is done with various hormones and nerves. And basically, the communication between the two is what allows something called metabolic adaptation to occur. To speak about this some more, we can define what metabolic adaptation is. It's a process by which the body alters how efficient it is at processing food for energy. Metabolism decreases when we start to lose weight. That's one of the features of metabolic adaptation. Many gut hormones involved, but one of the main ones, and the one that I talked to you about today during the consultation, is called ghrelin. Ghrelin is a key hunger hormone, and as far as we know, it's the most potent stimulator of hunger. Weight loss actually can increase ghrelin levels, causing you to feel more hungry, and this tends to happen just when you're starting to lose weight on your diet. This hormone, along with others, can alter our metabolism. To summarize what I probably said to you in the visit today, I described the scenario of someone trying to lose weight, and typically you can lose about 20 or 30 pounds before this metabolic adaptation kicks in. And around that time, a couple of different things happen. As stated here, your hunger hormones start to peak, as well as some stress hormones. And then also in your hypothalamus, your body is controlling your metabolism. So just when you're losing weight and you think you're making progress, your metabolism, I call it the metabolic rate thermostat, gets turned way down. And this really keeps you from losing weight. I'm sure you might have experienced that you kind of stall out at a certain amount of weight loss, and regardless of trying to work out more frequently or dieting even more intensely, that weight needle doesn't seem to move. Well, then in frustration, usually we give up, and then our weight actually comes back on more rapidly because that metabolic rate thermostat remains at a low set point until you overshoot that starting weight you were at before you initiated the diet. To show that a little more clearly, I created this table. So this is a table showing weight and time over time, and this is just a generality. Of course, from the moment we're born into adulthood, we tend to gain weight. There's a healthy amount of weight we should gain. But at some point, we overshoot what would be our healthy weight, and then we decide we want to lose weight. That's indicated here by the green star showing diet start. And we start to lose a little bit of weight, and then MA, metabolic adaptation, kicks in. All those things I talked about, slowing down your metabolism, increasing hunger hormones, and what have you. Frustration mounts, and guess what? You start gaining weight. Typically, that metabolic rate doesn't readjust until you've overshot. How convenient. And then guess what? You're going to try to diet again, and same pattern. You can lose a little bit, this time a little less than before metabolic adaptation kicks in, and you're going to gain weight again. And the cycle continues. Well, one more thing can happen that really throws people off, and that could be a stressor in your life, loss of a loved one, job stress, specifically for my ladies, pregnancy. So maybe you're trying to lose weight and then you get pregnant. Then you have a steep upswing in your weight gain. And I know we've all met or have that one friend in our friend circle who seems to be able to have as many children as she wants and doesn't seem to have trouble getting back to her pre-pregnancy weight, but for most people that's not possible. So guess what? You end up at a new high weight. You don't come back down to your pre-pregnancy weight. Metabolic adaptation still kicks in and the cycle continues. Overall, as a result of this pattern, on average, over our lifetime, there's unwanted weight gain that's difficult to lose. The older we get, the harder it gets. The slower our metabolism is, the more stressors there might be in life and other medical conditions further inhibiting all of this. Of course, medications we start can also play a big role. If you develop depression along the way, there's a lot of antidepressants that can actually cause you to gain weight. Steroids are a big one. Believe it or not, insulin. If you're diabetic and taking insulin actually, while it can help control your blood glucoses, it tends to cause weight gain. So where does bariatric surgery kind of stand up versus diet and exercise for weight loss? The NIH expert panel found that long-term weight loss is nearly impossible to maintain for those affected by severe obesity by any other means than weight loss surgery. Medical weight loss certainly has its role, and that's why it's indicated for a BMI of about 28 to 34.9. But we know when the NIH says severe obesity, they're referring to a BMI over 35 and more specifically BMI over 40. That's the BMI level that you really want to consider surgery, but I always support starting with a healthy trial of medical weight loss for anyone. Only 2 to 5% of people with severe obesity are able to keep that weight off at 5 years following a diet and exercise program. Most weight loss surgery patients keep weight off at 5 years. Again, I want to emphasize through this early part of the conversation a couple of things. I hope that metabolic adaptation information was really eye-opening for you. I may have highlighted in our interview that I use that to really drive home the point that here at Beltline, the moment you enter our doors, you're in a judgment-free zone. We know the science, we know how you got here, what you've been through, and so we know that it's not that you couldn't lose weight because you didn't care enough, didn't try hard enough. You're actually fighting evolutionary mechanisms that developed, at a time when we were more primitive. We didn't know where food was coming from or if we would be dealing with a long starvation period. So we have all these mechanisms and efficiencies to get excess, extract calories from things where, food items where it is densely packed in, and then we have, again, in our head, those control centers to prevent us from losing that weight. You're not alone. I think we know already, if you're walking around these days almost anywhere in the country, the prevalence of obesity is evident, but the statistic, and this may even be dated information, 34.9% of American adults live with obesity. Starting to see more of this in children. And I put this in here to highlight that you going through this journey, it's a good opportunity to reset the clock at home, set those good examples for your kids, and of course there's costs associated with all this too. All right, so what are the surgical options? I always begin this part of the talk by discussing normal function. So this is kind of a basic view of the normal abdominal anatomy: stomach, liver, gallbladder, pancreas. This bubbly structure here is the colon. We don't deal with that in weight loss surgery. But everything under here is the small intestine. So a couple of things that I want to point out. When you eat normally, food travels down the esophagus into the stomach, processes a little bit right here, But the moment it hits this area that I've indicated with a star, something special happens. I call it the key mixing area. But basically when food hits this area, it stimulates the release of multiple hormones and enzymes, and critical enzymes that come from the pancreas, as well as bile release from the liver and gallbladder to break that food down. So food doesn't just mechanically mix around in your stomach and intestine. That's how it magically breaks up. So you can absorb carbs, proteins, lipids. It's actually a chemical reaction. Each one of those primary macronutrients is extracted by mixing with these enzymes. So mixing happens here, and then on average, adults have anywhere from 16 to 20 feet of intestine to absorb all of those, the minimum essential calories, nutrients, vitamins, but also all the excess calories. Remember, this whole system evolved to be extremely efficient. It didn't realize over the years that now that we're lining our shelves with dense calories, that we can be less efficient. So it doesn't matter what you put in there, it's going to get every little drop out. When I say drop, I mean every carbohydrate and every lipid. So the way the surgeries work, I typically, when I talk about them, I'm drawing a line here to say that everything above this line is what I call top half surgery or upper abdominal surgery. Everything below this line, basically below this colon, is what I call lower abdominal surgery or bottom half surgery. And the way these surgeries work is that we impart changes on the stomach and or the intestine to drive the changes that we want. Important to note here that the intestinal length I try to indicate in this slide and subsequent slides with this red bracket, so keep an eye on it. Specifically, you'll notice that the size of it changes. We're going to start by talking about the vertical sleeve gastrectomy, also known as the sleeve. Here, this is the sleeve gastrectomy. Basically, this is what I call a top half only or upper abdominal only surgery. We don't do anything to go down here and alter the mixing point or the length of the intestine. What we do is we cut and remove 2/3 to 3/4 of the stomach forever. In doing so, we remove the stretchy muscle fibers. We also create a rigid banana-shaped tube here. A few bites of food hits this and makes you feel full. That's the restriction. The magic of this surgery is the metabolic part, which is brought into effect by removing this part of the stomach. This isn't just some sack of potatoes. Removing this actually removes a large amount of cells that create that one key hormone called ghrelin. So we remove the majority of the cells that make that hormone that drives hunger before and in between meals. And through more complex biochemistry, we now know that the removal of ghrelin somehow is really jacking up that metabolic rate thermostat. So the first time in your life, after you get off the OR table, we have reset that thermostat for you so that it no longer says, hey, wait a minute, I lost 20 pounds. Let me slow down this weight loss and hang on to this weight. We've driven up that metabolic rate so you can push past that threshold and really start to see some meaningful weight loss. This is done with a total of 5 incisions. I show them here that this may be slightly variable depending on your body habitus. Typically, this one here is more to the screen left, patient right side. But either way, 4 incisions. This is typically done robotically or laparoscopically. So you are looking at approximate sizes of those incisions on the body. And it takes 45 to 60 minutes to perform. We cut and remove 2/3 to 3/4 of the stomach, like I said. We don't manipulate the intestine again. This is primarily considered restrictive, but there is a strong metabolic component. Again, the size of this bracket hasn't changed because, again, we haven't manipulated intestine. The benefits of the sleeve, it's the most commonly performed bariatric procedure nationwide. It's restrictive. We make a small stomach, makes you fuller faster, but it's metabolic too in those ways that I described. driving down hunger, increasing metabolism. 75% of patients have a significant improvement in or resolution of disease such as diabetes, sleep apnea, high blood pressure, and hyperlipidemia. 60-80% excess body weight loss is what you can expect. What's your excess body weight loss? That's your current weight, what your ideal body weight. Excess body weight loss is your current body weight minus what should be your ideal body weight. So you can expect to lose anywhere from 60 to 80% of that up to at least 3 years out. This typically is done as a one-night stay in a hospital, but some places it is now an outpatient surgery. Potential complications or side effects after the sleeve. These are the key words that I want to highlight, but realize that there's many others. And closer to surgery time, when we go over that consent, we'll go over more detail of other risk factors related to, for example, general anesthesia. But when I list these, what I'm trying to do is list those that are what I consider to be more technically surgically related. So a leak is something that can happen anytime stomach or bowel that we've just cut on fails to heal. So wherever we cut bowel, there's typically something called a staple line. And when that area fails to heal, you can leak out. What are you leaking out? Bacteria, acid, saliva. Luckily, we can call these extremely safe surgeries these days because that leak rate for all comers is in the 0.5 to 1% range. When a leak happens, it will cause pain, high heart rate, fever. You're going to call and tell me that that's happening. I'm going to direct you to the ER. We're going to work you up. And guess what? Good chance we can fix this or at least nurse you through this. The number of people that go on to die from, quote, a leak is like 0.1% or 0.2%. So way smaller. There's also a small chance of something called a stricture. That's like a narrowing of that banana-shaped tube. I've personally never seen that happen. I think it has a lot to do with technique, but occasionally due to bad luck, scar tissue forms right in the area. Usually it happens about 1/2 to 2/3 of the way down that new sleeve, and it can cause kind of an obstruction, trouble getting food and liquids down, for example, throwing up. Reflux, I call this more of a side effect of the sleeve for some patients rather than a complication. It usually goes this way. If you come to the OR table with a history of heartburn, which we probably talked about that extensively today, 1/3 of patients get better because heartburn for most people is related to an unhealthy weight and bad eating habits. And once you're in our program and you get surgery for your weight, we're basically correcting the excess weight, and we're teaching you how to eat properly. A healthy diet can limit reflux symptoms. 1/3 of patients stay about the same, but apparently 20 to 30% of patients can get worsening heartburn problems. If we can't recover those symptoms with what's traditionally used for most people, medications, we can certainly talk about surgical options. And one of those remedying surgeries for this, and occasionally we have to do it, is conversion of that sleeve to a gastric bypass. Malnutrition, all the weight loss surgeries can put you at risk for malnutrition. The sleeve is the least likely to cause malnutrition. That's why I call it extremely rare with this surgery. However, once you're in our program and you've had a weight loss surgery, we're going to recommend, even with the sleeve, 1, sometimes 2 vitamins a day for the rest of your life. It is a little forgiving if you went, a period of time without the vitamins. The chances of you running into a true malnutrition-related problem is pretty slim because you're still, again, we haven't manipulated the intestines. There's a good amount of nutrients and critical vitamins you're going to extract from that healthy diet. But if you truly neglected it and you weren't eating well, you could run into problems. Of course, there's other complications, heart attacks, PE, blood clots, these type of things, but fortunately the percentage risk of all those is also very small. And I should also mention those things are lumped into others because they're the same risks you have if you're having any other abdominal surgery. So I don't want to create any unnecessary extra anxiety about undergoing weight loss surgery when you need to realize a lot of the risks that are lumped into others can happen with any surgery, including a routine gallbladder surgery. Some of our complication rates are actually lower for weight loss surgery than they are for other common surgeries. Hiatal hernia. What is a hiatal hernia? I go ahead and talk about this now after talking about the sleeve, but it's a separate diagnosis, not necessarily related to your weight loss surgery, but if identified, which we will try to work up and see if you have one of these, it is important to fix this at the time of weight loss surgery. A hiatal hernia is one of the common contributors to gastroesophageal reflux disease. 21% of our bariatric patients will have a hiatal hernia, and up to 27% of our bariatric patients will have some degree of GERD. And believe it or not, there is something called asymptomatic gastroesophageal reflux disease too, where you may be silently refluxing and not really aware. If present, again, we want to repair this, especially with a sleeve, and I'll explain why momentarily. But just to define what this is, the hiatus, this first part of this word, is actually a hole we're designed to have. It's a hole in the diaphragm where the esophagus passes from the chest into the belly. It's supposed to be there, and when it's working perfectly well, it's a snug bundle of muscles that wrap right around the distal esophagus. This is the distal esophagus right here, and at the end of that esophagus there should also be something called the distal esophageal sphincter. Technically should be right at the level of the muscle or a couple centimeters below to function optimally. And as this arrow indicates here, when it's working properly, it's preventing gastric contents and acid from going up. When we have extra weight on our belly, and we think that extra weight causes increased pressure on the belly, it tends to push things up into this hiatus and dilated it. Once it's dilated to where it's not snugly wrapping the esophagus, that's called a hernia. Not unlike a belly button hernia, which is really a dilation of a hole that we all used to have when we were connected to mom through our umbilical cord. When everything goes well, that umbilical cord hole becomes a pinhole. But when that pinhole gets dilated because of intra-abdominal pressure, typically pressure in your belly if you're a female and you have multiple pregnancies, that hole dilates. Well, the diaphragm, the diaphragmatic hiatus, can also dilate. The problem is once it dilates and it's not reinforcing or augmenting the function of that lower esophageal sphincter, we can start to see increasing levels of reflux, heartburn, gastroesophageal reflux disease. And if it gets big enough, actually, guess what? The top part of the stomach starts to migrate into the chest, and left unchecked, acid damage here can cause something called esophagitis. So it's important to fix this when we find it to limit the chances of that unwanted side effect of reflux, specifically with the sleeve, since the sleeve, we theorize that it's a tube that's a high pressure system. It's already going to increase the chances potentially of reflux, and if you have a hiatal hernia, that those chances may be higher. So here at Beltline, we aggressively try to identify these, and we want to be aware of them. We want to fix them if we can, and at the very least, I want to document the size of even a minute one or silent reflux. So if you develop those symptoms later, we can have like comparison studies too, and kind of guide you through that treatment if it's needed. The next surgery we want to talk about is called the Roux-en-Y gastric bypass, also known as RNY-GBP, or the bypass, as most people call it when they come to the office. The way this surgery works, again, splitting things up into top half, bottom half, is as follows. Number one, we take that stomach and create a teacup-sized pouch instead of a long tubular banana-shaped stomach. We now create this teacup-sized pouch. Obviously, a couple bites of food can hit that and make you feel very full. For the second half of the surgery, we go down here below the colon now, and we cut and divide the intestine and then reroute it to that pouch. In doing so, notice what happens. Basically, we create a situation after creating that teacup-sized pouch and rerouting intestine where now food can travel through the intestine relatively unprocessed, and it remains that way until it meets up with those critical digestive enzymes and bile that I mentioned before. Well, with the Roux-en-Y gastric bypass and the rerouting, I make it to where those critical enzymes don't meet that food until further downstream. Effectively, we change that critical mixing point, whereas it was here, now it's going to be down here. In doing so, remember, for you to extract good and bad calories from what you ate, it has to be mixed with those digestive enzymes. And then the efficiency of extracting those calories from that food into your bloodstream requires all of that 16 to 20 feet of intestine to absorb those mixed contents. Now, because I delayed where those enzymes meet up with the food, effectively I have decreased the amount of bowel left over down here to absorb those calories. So I estimate we reduced that intestinal length from 16 to 20 feet to about 8 to 10 feet. That's what creates something called malabsorption or bad absorbing. And you'll notice that my red bracket here is starting to shrink. It's getting shorter. Again, this is showing the intestine left after that mixing point. This is done with a total of 6 incisions. They're shown here. These are pretty much actual sizes of these. This takes anywhere from 75 to 105 minutes to perform. As I'll probably tell you, in pre-op, surgery takes as long as it needs to be done safely. These are just kind of average time so you have an idea. Benefits of the gastric bypass. Again, restrictive pouch, fuller, faster. Malabsorptive, that's everything I talked about where we decrease the ability for you to absorb bad calories. Decreased gastric hormone and other hormone production. You know, it's not just all about ghrelin. There's a variety of other hormones and peptides at play, and the bypass in its own way affects your metabolism and other things because we decrease the exposure of a large segment of intestine and stomach to food, and it's usually actually the food passing through there is what stimulates the release of hormones. So by limiting the contact that food is making with certain segments of that intestine and stomach, we tend to decrease various other hormone levels. 60 to 80% excess weight loss at 3 years post-gastric bypass. You know, for me, having done some of the latest training and heard some of the latest theories about how all this works, you know, head-to-head in the initial period, sleeve and bypass are actually very similar in terms of what you can expect for weight loss. Where I do think personally that the bypass is superior is longer term for weight loss maintenance. I think it's easier to maintain that weight if you, quote, fall off your diet wagon more than 3 years after surgery. Because if some stressor or something's causing you to eat the wrong stuff, we've done that whole second half, lower half of that surgery to make it harder to absorb unwanted or excess calories, right? That's everything I just said. So who, in my hands, who I really, you know, I'm going to talk to you about all these surgeries. I ultimately want patients to pick their surgery, but who I tend to recommend more strongly to get the bypass are those patients with severe reflux already. You've dealt with heartburn for many years, or you have what's considered moderate to severe heartburn, especially if you don't even have an impressive hiatal hernia or something I can act on at the time of a sleeve. You know, that 20 to 30% chance that that reflux is going to get worse, that's probably enough of a reason right there to consider bypass over the sleeve to keep that risk of reflux at bay. We are seeing some breakthrough reflux with the bypass as well, but it's far more rare than it is with the sleeve. It's also a superior surgery in terms of curing more, I'd say more advanced diabetes. If you've already been a type 2 diabetic for a couple of years or a few years, especially if you're taking insulin, you want to be off that insulin and cured of that. I think you really need to consider gastric bypass instead of a sleeve. Sleeve is very effective, especially for early diabetes. There's research that says the sleeve and the bypass are about the same. But if you've had diabetes has set in for a while, I think that's going to put a little point in the bypass arm of things when you're making the decision. It's a 1 to 2 night stay in the hospital to do this as well. So you can see subtle increases in the OR time doesn't necessarily mean suddenly that patients are having to stay like a long time in the hospital. I get questions all the time about what's my downtime going to be. The beauty of this minimally invasive robotic laparoscopic surgery is return to normal function. I'll go ahead and say it now. With any of my surgeries, I tell patients 90% recovered. 90% of patients are 90% back to normal by that 2-week follow-up. Especially my computer job type of patients who can work from home, you could be back at it as early as 3 to 5 days after surgery. I typically advise you go ahead and take 2 weeks off, let your employer know you might need 2 weeks, but especially if it's not a very hands-on, heavy lifting type of manual labor job, you could be back in as early as 5 to 7 days, 10 days. We can always retroactively date the necessary paperwork. I'll go ahead and add more details here. After any of these surgeries, we expect, encourage, if not demand, that you need to be walking early after surgery. It's dangerous not to. And there's really nothing keeping you from walking. You will be sore. I typically describe it as sore like you did 1,000 sit-ups with occasional sharp pain. I can also tell you some other data related to pain. When I was in Austin, Texas, there was a study done on the pain medicine regimen that I send you home with. We surveyed hundreds and hundreds of patients. Something like 93% of patients never reported a pain greater than 6 out of 10. On a scale, of course, everyone's scale can be slightly different, but that's a non-narcotic pain regimen that prevented most people from having anything like a 7 to 10 out of 10 pain. I fully expect people to be able to do most of their home activities within a day or two of surgery using those medications. So that's what you should expect for any of these in those small incisions. Potential complications after the bypass. Again, that word leak. So anywhere we cut intestine and stomach, there's a chance it doesn't heal and it leaks. Fortunately, we're looking at typically 1% or less chance that something like that happens. Stricture, again, that place where we connected bowel to that little pouch called the GJ connection point, that can stricture for some patients, up to 2% chance. Ulcer, there's about a 3 to 5% lifetime chance that you get an ulcer right at the end of that pouch. And typically, the people who get that are smokers and people who forget that they had a bypass and then they constantly have to take NSAIDs, NSAIDs, that's a class of medication, also known as anti-inflammatories, typically your Aleve, aspirin, ibuprofen, Advil, and then big no-no, BC powders and Goodies powders. Those things, if taken consistently for several days, can really put you at risk for an ulcer. So if you're a patient of mine, you're already heavily reliant on this for some really messed up back or knee issue, it really may steer us away from the bypass altogether. But the more common scenario is, if you're already on that and relying on that, we won't do the bypass. But the more common situation is you get a bypass in your 30s or 40s, you don't throw out a disc or a knee until you're in your 50s or 60s, and by that point, you've had satisfactory weight loss, your life's been changed, you're not thinking about that bypass, and you start popping Advil, right? Because it's a great medication, it's available over the counter. You just always have to remember that Dr. D said after bypass, no more NSAIDs, NSAIDs, and reach for Tylenol first. Reach for a pain patch that's over the counter that you can throw on your knee. Ask your me or your primary care doctor or orthopedic doctor for other options. Maybe there's a role for injections instead. All those things can limit the risk of that ulcer. Next, there's always a chance of an obstruction. It's about a 1% lifetime risk that happens, where the bowel gets twisted or kinked on itself. It's a good time to point out, people always say, man, that sleeve seems safer. Technically, you're not wrong. I think it is safer when you consider specifically these two things. With sleeves, we really just don't see ulcers and bowel obstructions. It's if you're really worried about these two things, even though there's such a low rate possibility of it happening, then yeah, you may want to stick with the sleeve. But overall, head-to-head, chances of something bad happening in that what we consider that early perioperative period, they're really the same. But bypass does expose you to two potential things that a sleeve doesn't. But remember, if we're going to choose a bypass, there's got to be some extra benefit. I got bad reflux already. I need a slightly better weight loss long term. I'm worried about regaining weight. I didn't mention it, but technically, once you're beyond that initial couple of years, bypass patients tend to, on average, have a 6 to 8% better weight loss compared to sleeves. So I'm not saying that truly they're the same. There is better weight loss, but that's especially appreciated when you follow patients out longer term. Next, dumping syndrome. I listed under complications, but please look at this in red. It's now considered a side effect, not a complication. What it is caused by is eating inappropriate things we don't want you to eat on your diet, and eating in an inappropriate manner. So when you get your dietitian education, you're not only going to learn about your lifetime diet, the proper way to eat, you're going to get education on how to chew, and even subtle things like don't drink water 30 minutes before, during, or 30 minutes after a meal. Let that food go through without water diluting it and breaking it apart. Specifically, if you evacuate food out of your pouch too quickly into that intestine, it doesn't like it. It's not used to seeing unprocessed, dense chunks of food that haven't been broken down by those enzymes. So when that happens, it causes these symptoms. I tend to tell people that it makes you feel the way it sounds. So nausea, vomiting, diarrhea, cramps, flushing, dizziness, heart racing. Typically, this only needs to happen 1 or 2 times for you to realize, oh yeah, I forgot to eat the way my dietitian said. I actually, secretly as a surgeon, I like dumping syndrome because it's going to keep you on track, really. Because when you eat the stuff you're not supposed to is when it tends to get provoked. Maybe this is another reason why the bypass is better long-term at helping people stay on track. Realize that it's primarily treated by, again, reviewing how to eat and what to eat. 90% of people, once they've experienced it and they talk to me or the dietitian, it like doesn't happen again. On occasion, if there's breakthrough dumping syndrome effects, despite you proving that you're eating the right way, there are medicines too. So really, this is not a life-threatening complication. It's not even a complication. It's a side effect because of the way we reorient the intestine. Malnutrition, again, I'm going to put this on every slide. I call it rare, not extremely rare, so it is potentially possible. And it's important now that you're taking 2 to 3 vitamins a day for the rest of your life. Missing a few months can cause some serious irreversible damage. So you want to be aware of the vitamin education and taking the vitamins, and the dietitians will go over that with you extensively. This used to be a much bigger problem with bypass and the neck surgery I'm talking to you about, the malnutrition piece. But in the last 5 years especially, the number of companies that have come out with bariatric formulated vitamins at a really competitive cost, the number of protein supplements and shakes we have, I mean, in my mind, you have to be basically negligent trying not to do the right thing and starving yourself, or in some extreme scenario to run into a true malnutrition. But I definitely don't want to downplay it. It's significant. It's managed by being educated. Staying on top of your vitamins is the easiest thing you can do. Meeting up with us, even beyond that first year, when you follow up with us, annually or biannually, we want to check nutrition labs. We want to detect nutritional deficiencies and make sure we avoid these problems. Of course, as with the other slides, any surgery, when you sign your consent or you really check into a hospital, there's a long list of potential things that can happen. We just have to trust that the risk of those things is small. The benefits of weight loss surgery, longer life span, curing these illnesses which we know will cause you problems long term, having a better quality of life. There's even a cancer reduction after weight loss surgery. I should say cancer risk reduction for multiple forms of cancer after weight loss surgery. These are the reasons that we're going to hope for that anywhere from 98 to 99% chance that things go well. We're going to plan and prepare and try to avoid those 1 to 2% risk factors as best as we can by optimizing you. But sometimes there's bad luck when we're trying to do especially good things for ourselves. Biliopancreatic diversion with duodenal switch. Lot of words and letters here. So this surgery is called the switch, or the DS. It's described by many patients as the most invasive or the most extreme. The doctor in me says, why don't we just call it the most effective weight loss surgery? Now, this is a picture of what it looks like. I can simplify this here. Total of 6 incisions, same as the bypass. It takes a little longer to do, 1 hour and 45, 2 hours and 15 minutes sometimes. It's essentially a sleeve for the top half surgery. Upper abdominal surgery is a sleeve, just like the sleeve before. In the bottom half surgery, the lower abdominal part is essentially a long intestinal bypass. So in my mind, it's a sleeve plus a bypass. We change that critical mixing point again. I'll show them to you. Here's that star. This is where mixing happens in the normal belly before surgery. It's changed all the way down here to the bottom, close to the bottom of this image. In doing so, we reduce the effective length of the intestine after mixing again. So now look how much intestine it is traveled by those enzymes before it's ever allowed to meet up with food. In doing so, again, now we have a tiny red bracket, right? Previously it was like this long. With the sleeve it was like this long. Now it's like this tiny little bracket here. I estimate that we effectively reduce that bowel mixing and absorbing capacity from 16 to 20 feet down to about 3 or 4 feet. So yeah, very extreme. But it causes a significant malabsorption. We can say extreme, but what are the benefits? Before I go over that, I do want to mention this. So this is actually the newest kind of sexiest surgery offered by weight loss surgeons. The problem is, and the reason I didn't cover it in the cover it with you today in the consultation, is it seems like 7 times out of 10 this is not being approved by insurances. They haven't caught up, as is usually the case, with the science. So there's great science. There's been thousands of these surgeries done, but they still want to designate it as experimental. The beauty of this surgery is we're seeing the same results. So this is a picture of that Sadie, and you'll have to remember from the previous slide when I showed you the DS, we had a connection here. The sleeve was connected to intestine, but also intestine was connected to itself here. We call that having 2 anastomoses. When we do this so-called Sadie, the newer version of the duodenal switch, we don't do that second connection. So it kind of saves you the risk of some technical challenges with making 2 connections. Of course, anywhere you have a connection, there's an additional chance of leak. You know, what we're seeing with this surgery is all that benefit from the true original duodenal switch in terms of excess body weight loss being in the 90% or higher range, and over 90% chance of curing your medical conditions, with a trend towards less risk or incidence of malnutrition. However, I definitely have talked to surgeons, and based on what I've seen, again, having completed training recently, I think with the advent of better education, better program follow-up, which like what we offer, and generally the wide variety of specifically formulated vitamins and protein shakes, malnutrition's really it's not as prevalent as it was when these surgeries were kind of invented. So anyway, I would love to offer this. I think it's always worth screening insurance to see if they'll allow us to. but as it stands, so as not to accidentally create a high cost for you or a surprise bill, it's best to stick with what insurance has approved, and typically that's the traditional duodenal switch. So anyway, that's an aside about that surgery there. So let's talk about the benefits of the switch. Again, restriction and malabsorption, the way I described on that picture showing the operation. 80. So what's the true benefit here, y'all? 80 to 90%, I say 90+% excess body weight loss at 4 years post-procedure. This is why I say it's the most effective. If we're really targeting our true ideal body weight, your best chance of getting there is going to be this surgery. And it's been proven to be long-term durable. I can tell you I've seen patients that have had a duodenal switch for beyond 10, 15, 20 years, and they have maintained weight loss. Patients have a greater than 90% chance of improving their obesity-related comorbid conditions, such as those previously listed. So it's, more effective weight loss means more chance that you're going to cure those medical problems. At 12 months, for example, 96% of patients showed type 2 diabetes remission and a hemoglobin A1C less than 6. That's a very high percentage, 96%. Still, 1 to 2 night hospital stay, still done like I showed you, 6 small incisions, about a 2-hour operation. Who am I going to kind of push a switch for? I really start talking about this more strongly once you have a BMI over 50, really, and then multiple medical problems that have set in for a long time. And especially if your BMI is over 60 or above, I think, no weight loss surgery is a truly bad option, but you need to be considering this surgery. If you're going to go in and undergo the risks at that high BMI of surgery, we want to do one and done type of surgery, and we want to get you the most effective results and durable results, in my opinion. Potential complications, you've seen it again, leak. This combined a sleeve and a bypass, so you can imagine that there's some combined risk factors here. But curiously, we're not seeing ulcers with the duodenal switch like we do with bypasses. And for whatever reason, obstructions are less common. Part of me thinks it's because overall we do less switches than we do bypasses and sleeves. And I think if we ever get to a point where we're doing primarily duodenal switches, we could see more things come up. The bottom line is this: we're still talking about those 1 to 2% chances, 0.5 to 2% chances of something like that happening. Malnutrition is a bigger deal. I think I highlighted that. Again, it's rare, not extremely rare, kind of rare. This is, a potential complication for a reason. We mitigate that by taking 3 to 4 vitamins a day for life. Missing a few weeks now can be a big deal. Of course, there's others. So we've kind of reached the end here. This is the last slide. This is to review what happens next after that first consultation. Basically, after you met me today, you should have gone and met your new patient coordinator. If it was telehealth, you should have been called shortly after our telehealth visit. If you didn't get a call or didn't get to meet them because they were tied up or you had to run back to work, rest assured, usually within 24 hours, that coordinator will reach out to you anyway. But I'm going to say it again in this slide. You're your own advocate. You're the one that wants to get this done. We are here. We have excellent staff to help you get there. But if you haven't heard in 24 hours, don't wait 5 days and 10 days and then call frustrated because we never followed up. Just call. We'd be happy to call you. Our coordinators give out their emails directly, so you can always be in touch. And we have a whole separate team of people who are, I'm going to talk to you next about the checklist that you have to get done. There's a whole separate team that's also keeping track of where you are in terms of getting tests done. They should call you, but we have hundreds, thousands of patients. You want to get this done for your health, do not hesitate to call and check in and see where things are, okay? Let's talk about that to-do list. Basically, first of all, the list I'm about to show you is basically the full gamut of potential things that we would have discussed and ordered. Not everyone needs to do everything on this list, so don't pull up this slide and start asking our MAs and patient coordinators like, why didn't I do this or that? Usually in your note for the day, we will specify what we want to have done. And one of the things that I'm very prideful of working for Beltline Health is we've made it our mission to make as much of this, as much of the stuff you need to get done available to you in one place. So we are a one-stop shop for most of these things. And if we're not physically, we do know places to send you to streamline this as much as possible. So what's the to-do list? Sometimes you may need a true medical weight loss referral. Who's going to get this? If you walked in the office today thinking you actually want a medical weight loss, well, we're going to make that appointment for you. Anyone who wants to try medical weight loss before they commit to surgical weight loss. Sometimes I'll send, if you're a revisional surgery patient and we talk today, we almost always mandate 6 months of medical weight loss to relearn things, maybe kick off some weight loss with our trained bariatrician, Dr. McDaniel, who has a whole new toolkit full of new medications that can help you lose weight. The other role for seeing a true medical weight loss doctor like Dr. McDaniel would be if you're a super high BMI, we're talking about potentially risky surgery. I'm going to want you to spend some time with Dr. McDaniel and maybe even use those medications to see some weight come off just for safe surgery. Dietitian education. This is the only thing I've probably highlighted in the entire slideshow. I'm going to go ahead and say what I tend to say to everyone in our consultation today. If you think your surgeon is Batman, then the dietitian is definitely Robin. Okay? We are a dynamic duo. Weight loss surgery and lifetime diet have to go together. They are the same thing. Okay? And so the surgeons and the dietitians also have to work together. Your dietitian, everyone gets a minimum of 3 classes with their dietitian. Pre and post-op diet's going to be covered, vitamin education, where to get them, and so much more. Our dietitians are always enthusiastic. They welcome certain questions about, how, without getting out of hand, how can you subtly customize a diet to suit your needs? How can you be functional when you want to be out and social after you've lost weight? What can you select from the menu so you can stick with the program? So again, you may think your surgeon's Batman because surgery is such a big deal, right? And if that's the case, then the dietitian is definitely Robin. We're the dynamic duo. However, I actually think for your long-term success, I truly believe this, the diet, committing to the lifetime diet change, using those dietitians is actually more valuable, more important for long-term success. I promise you, as excited as you are about surgery, 2 years from now, 5 years from now, you probably won't remember much about the surgery or your surgeon. I mean, I would hope you do. But if everything goes really well, you're not going to think about the surgery, you're not going to think about me, but you need to never forget what you learned in terms of your bariatric diet. Don't be afraid to follow up with us regarding this. In fact, before you get to your first dietitian class, start a notebook, My Weight Loss Journey. The front half of that, be ready to hole punch and put in their handouts. Please don't lose them. The back half can be loose leaf paper to start your diet journaling. I think that's a huge component of long-term success as well. So last thing I'm going to use this picture for is this. You may think I'm the surgeon, and you may think I'm Batman, and you may think the dietitian's Robin, but I actually think it's reversed. I think the dietitian is that important. They're Batman, and us surgeons are Robin, the sidekick. Remember, the surgeon's just giving you a tool. If you don't use that thing properly, if you don't maintain it properly, like taking your car to the mechanic, checking in with us, you will be disappointed. Psychological clearance, most insurances require that. I think it's a great idea. We don't think you're crazy. We want to make sure you're not eating because of an undiagnosed depression or some kind of eating disorder, right? Those are things that could cause you harm if we add in a weight loss surgery. Medical clearance, we're going to get that. That's basically a letter from your medical doctor saying that you spoke about it. We have a game plan for your medical problems, and everyone's cool with you getting surgery. Frontera testing. Frontera is the company we use to do our basically heart and lung testing to make sure you're safe to go under general anesthesia. They also go ahead and screen your legs for blood clots because you don't want to dislodge one of those at the time of surgery. And we do screening ultrasounds of gallbladders. Here's why I do it. Chances are if you've rapidly cycled weight in your life, so one or two of those diets were pretty successful, you lost 50 pounds or something. If you're a female in your 30s or 40s, you've had rapid weight gain and loss with each pregnancy, there's a good chance you already have silent gallstones. Silent gallstones are stones in your gallbladder that have formed. They're not painful yet, but get this, something like 34% of weight loss surgery patients go on to form new stones, more stones, or something called bile sludge. And something like 8% of all weight loss surgery patients eventually need their gallbladder removed because those stones hurt. Depending on what surgery you get, they can cause even more problems. So I really like ultrasounds of the gallbladder, especially because if you have 0 stones before surgery, there's some good data that says we should put you on a medicine to prevent gallstones. If you already have a stone or two in there, we know the medicines don't dissolve active stones. So chances are in that scenario, we don't need to hit you with 6 months of medicine. And if and when your gallbladder acts up, we can remove it. And guess what? You'll be at a healthier weight for a safer gallbladder surgery. But we can also use that time to ultrasound the liver, which the gallbladder lives on, to see if you have signs of fatty liver disease too. So here's that list of stuff they offer. Again, we do all this in pretty much one visit in our office. It's an excellent service to have. I know our anesthesiologists love it so much. They almost wonder why someone didn't get the testing if at all we skip that. I'll tell you, if you are on the younger side, you're actively working out, you've never experienced chest pain, sometimes some of this testing can be overkill, but it's up to us to decide who needs no testing, at least Frontera testing, and sometimes patients need true cardiology clearance, like you got to go see a cardiologist. Another thing we do is I usually recommend sleep studies, especially if you did the screening for sleep apnea and you got a certain score. Sometimes insurances are requiring it too. Before you hesitate to do this, because it could be uncomfortable, time-consuming, expensive, consider this. Undiagnosed sleep apnea is a major contributor to an inability to lose weight and maintain weight loss. So people who treated their sleep apnea, on average saw more effective weight loss and kept it off longer. And not to mention, if you have undiagnosed sleep apnea, not treating that, you're hurting yourself in terms of your energy levels, stress levels, you name it. Sleep, we spend a third of our life sleeping. You got to have quality sleep. Some things have changed that can make this better. So a lot of our patients qualify for home sleep studies. It's not like it used to be where you go to a facility, you have all these wires coming out of your head and whatnot. Machines, this actual CPAP machines have gotten lighter, more efficient, easier to clean. So don't discount that. I will tell you, if you scored pretty low on the screening and your insurance doesn't require it, if it really is a big headache and it's costing money out of pocket, maybe you can skip it, but you have to talk to me about that, because again, all the weight loss surgeries offer such a high cure rate for this. If we're getting to surgery pretty quickly and we're going to knock this out, maybe you don't need to have all that done, but please don't undervalue it, and make sure we talk about it before you make some decision to skip it. EGD and upper GI, what are these? So before your visit today, we should have done a gastroesophageal reflux disease, GERD, or heartburn-like screening survey. If you had a certain score on that, I'm going to recommend we do an EGD, an endoscopy. This is just like getting a colonoscopy, except instead of looking at your colon, we're looking at your stomach. You need to take a day off. You are sedated. You won't remember anything. You don't have to drink a nasty prep. My time doing this procedure is about 15 minutes, but your time in the hospital or outpatient surgery center is about 2 to 3 hours. You will need a ride. What this allows us to do, these two studies, the other thing called an upper GI x-ray where you drink contrast, shoot an x-ray, these things are going to help us, rule out some random unexpected like polyp or mass where I'm about to go staple. I would hate to staple on a mass and then cause all sorts of problems. That's pretty rare. The more common things we look for, that hiatal hernia. I want to find it. I don't want to be surprised by it at the time of surgery. I want to let your insurance know about it so they pay for that part of the surgery. We want to do biopsies to rule out a certain bacteria that can provoke ulcers, especially if you're getting a bypass. If we're doing revisions, we have to take a look. My surgical brain needs to see what that anatomy looks like for good planning. Also, on about up to 7% of the time, an EGD and this x-ray could change our operative plan. A common scenario being, okay, you think you're a great candidate for a sleeve, you're not perceiving any heartburn well, your upper GI showed a horrible reflux all the way up to your throat. And when I did an EGD, I actually saw some signs of advanced esophagitis. You know, that may be a tiebreaker. If you're on the fence about a sleeve and a bypass, I would say if we saw that kind of damage, but maybe we need to consider a bypass. So lots of valuable information to get from that. Again, we are here to help, and generally we'll check in on your progress. We do have teams of people to do that. But the bottom line is this: when you get these items done, this checklist, whichever one was set of things were set up for you, that's when you'll be ready to proceed to the next step, which is scheduling that surgery, right? So be proactive. You are the captain of your own ship, so to speak. So we just want to be part of your key crew members and help you get there.